Welcome to Chiba's Visiting Lecture Series. I'm Parminder Sachdev, co-director of the Centre for Healthy Brain Aging at the University of New South Wales in Sydney. Before we begin, I would like to acknowledge the medical people who are the custodians of the land on which this center is located and pay my respects to their elders, past, present, and emerging. It is my privilege today to introduce my good friend, Professor Tony David. He's, as you know, a foremost neuropsychiatrist internationally. He's currently Professor of Mental Health and Sackler Chair, and also the Director of the Institute of Mental Health at University College London. He's also Honorary Consultant at the National Hospital, Queen Square. Now, Professor David trained in medicine from Glasgow University and then went on to do psychiatry at the Maudsley Hospital. And prior to coming to UCL, he was Vice Dean of Academic Psychiatry at King's College London at the Institute of Psychiatry. He has a wide range of research interests spanning various aspects of neuropsychiatry. And in particular, I would mention schizophrenia, medically unexplained syndromes, and neuroimaging. And he has authored over 600 publications in peer-reviewed journals. Now, I cannot go through the list completely. I mean, his CV, of course, runs over several hundred pages, I presume. But I'll just mention a few achievements. One, of course, that in 2018, he delivered King's lectures on psychiatry, science, and society. He's been the editor of Cognitive Neuropsychiatry, and I think he probably initiated that journal, founded that journal. And he's also published a book for the lay reader, and that's entitled Into the Abyss, a neuropsychiatrist's notes on troubled minds, which is published in 2020 and is available on Amazon. So he's here in person today, which is, of course, also a privilege. And following his talk, there will be a live Q&A. And of course, if you have any questions through the talk, please put in your questions through the Q&A button at the bottom of the screen. I suggest that you use the Q&A button and not the chat button for your questions. Now, thank you everyone for attending from around the world. And I would now welcome Professor David for his talk, Functional Stroke, a New Challenge for Stroke Services and Neuropsychiatry. Tony.
Thank you very much, Parminder, for that very nice introduction. And it's a great privilege to be invited to your meeting and to speak to the guests. So let's get on with it. This is the most anxiety-provoking part of the day where we try and share screens. So I'm going to talk about what we call functional stroke, or some people call functional stroke mimic, and I'll explain what that is. And it's a phenomenon that's been around a long time, but we're seeing it particularly because of the way stroke services have developed over the recent years. So I don't know what it's like in your part of the world, but over in the UK and Europe, there's been a big push for very rapid response of medical services to an impending stroke. And we've got this acronym FAST, face, arms, speech, time. The idea being as soon as there might be the beginning symptoms of a stroke, the person dials the emergency services and gets to hospital as soon as possible. And so there's this public health campaign, which I think features these rather disturbing images, designed, I suppose, to frighten people into responding quickly. Here's another one. A stroke seen as a sort of explosion inside your head. As I say, slightly disturbing images. And here is a male victim with the FAST acronym. So the whole point is to reduce what the neurologists call door to needle time. So the minute you have a suspected stroke, you're whisked to the hospital, you're diverted to the stroke specialist team, you have a brain scan, a CT scan, and if necessary, you're given clot busting drugs. And this really has revolutionized stroke care and has reduced mortality and greatly reduced the morbidity from stroke. So it's been, you know, one of the greatest innovations in neuropsychiatry, you could say, over the last 20 years. And here's a kind of flow diagram that I think illustrates what's supposed to happen. If you start at the top, you have the acute suspected stroke. There's a triage process. If there's a high probability of stroke, the patient is diverted towards a stroke unit and treated, depending on the time of their symptoms, etc. And then you can see here in red, possible stroke goes down a slightly different route, sometimes requiring further imaging, MRI imaging. And then you can see there in the right-hand corner, if the clinical symptoms do not suggest definite stroke, you end up going down this route here. Address underlying condition, refer to neurology or medicine, because of course it may be some other medical condition, not a stroke, but another medical condition, or it could be not a diagnosable medical condition, and the idea is refer to psychiatry for functional mimics. Now here's a cartoon that I think illustrates this, and it's not meant to make fun of the patient's predicament, but rather it is making fun of the services. So if it's a case of hypochondria, going to refer you to some imaginary colleague, and that's the truth of the matter, is that the colleagues supposed to manage a person with a functional stroke are often imaginary. They don't really exist within existing stroke services. There's a real gap there, and I'm going to talk about why we need to fill that gap. So first of all, let's talk a little bit about what is a functional stroke and what does it look like. And I think this very much ties in with recent work in functional neurological disorders and a much greater, broader understanding that we now have of these conditions. And we're much better at diagnosing them on the basis of some positive signs as well as the lack of other conditions. So here's a very nice illustration. If you look at the panel A, this is a way that you test for functional weakness. So this lady here has a weak right leg, and when the power of that leg is tested by asking the patient to press down on the chair or on the couch with the right leg, it's weak. However, when you're testing the power in the good leg, in the left leg, there's a reflex contraction of the same muscles on the right. And so it demonstrates that there is power is retained in the weak leg. And when the person's attention is directed away from that, the power returns. So it's a problem of attention to some extent. And the challenge is to unlock the power that remains in the weak leg. Then there's some other examples of this. So in the panel C, the person there has a weak right arm. They're asked to put both arms out in front of them, close their eyes. And what normally happens is the right arm sort of turns inward. And this is drift with pronation. So that's because the muscles that pronate the limb are always stronger than those that pull in the other direction, even if their overall limb is weak. But in functional weakness, that doesn't happen. So there may be some drift of the arm, but it doesn't tend to pull in. And then on panel D, you can see that the person at first glance looks like they might have a weak face drooping on the left side, on their left. But in fact, it's that their muscles on the left are pulling their face in that direction. So that's different from what it would look like if this was a vascular stroke. So there are good ways of distinguishing functional stroke or functional stroke mimic from a vascular stroke. So going back to the clinical picture, so a person has symptoms of a stroke, they're assessed in the accident and emergency, and then they're given a scan and they're sent to what we call in the UK a hyperacute stroke unit, or HASU. So what my colleagues and I did at King's College Hospital was look at all of the admissions in 1 year to see how many ended up being true cases of stroke, how many had a medical condition that was mimicking a stroke, and how many had a functional condition mimicking the stroke, and to see what happens. So first of all, we had to have a system of classification, and this is a rather detailed slide, but basically when a person comes in with a suspected functional condition, it's quite important to decide whether this is a functional overlay, function on top of some other condition, and the confidence with which you can make the diagnosis. And this often needs a consensus. So in this study, we went back over the case notes and made sure that there was a consensus that if we were calling someone functional stroke, there was a consensus that that was the decision of some experienced clinician, that it was very much completely functional, or at least largely functional. And that's what makes this study that I'm going to discuss a bit different from other surveys, where the attempt to diagnose a functional condition is not usually made with such rigor. So this is the bottom line of the study. So out of over 1,000 people admitted to a stroke unit, you can see in blue, around about 3/4 did in fact have a stroke, a vascular accident. And then the other part of the pie are the non-stroke mimics. And in red here, you have medical mimics, and that could be a brain tumor, demyelination, seizure. And we classified 8% of the total having a functional disorder. And this is higher than other surveys, which I'll show you, because I think we had the experience to make that diagnosis. So I'm going to show you other pie charts which have the same format from other studies, just to sort of get an idea of the consistency. So here's a similar survey that was done at a neighboring London hospital. Very similar results. 3/4 have a stroke, and then you have this other quarter that have a mimic. And in this case, the largest subgroup are the medical mimics, and then you have other sort of ragbag category. Some are called functional mimics, but then you've got another group that are called unexplained, and then you have another group called headache, migraine, which I think are probably functional cases. Here's another study from Strasbourg, slightly smaller proportion having a stroke diagnosis, actually, but the same sort of pattern. So it seems that there's been a lot of studies that have looked at these proportions, and we did a meta-analysis, and here are the details. But to cut a long story short, there are over 100 studies that we could draw on. 70 actually gave a figure for functional disorders. These are surveys of prevalence of stroke mimics in stroke services. So we're talking about over 80,000 patients overall. So a very large survey now, because this idea of stroke units has really swept the world. So this is a pie chart made up from the meta-analysis. And as you can see, exactly 75% overall of these tens of thousands of cases will turn out to have a stroke, and then 25% don't have a stroke. But if you're not really looking out, and if you don't have the confidence and experience to diagnose functional stroke, you end up with a small proportion. But I suspect that the reality is larger than that. Of course, you still do get this number of medical conditions that mimic strokes coming into the stroke units. This is from the meta-analysis showing the proportion of medical mimics, stroke mimics, that have a functional diagnosis. And you can see that our study from King's is what has one of the highest proportions, but not the highest. Anyway, so back to our own study. I'm going to look at this, drill down to compare this with what the meta-analysis shows. So let's first look at, to try and characterize these different kinds of cases. And first of all, let's look at gender. So in blue, we've got our own study, and in red, we've got the results of the meta-analysis. And this is just to show, to see whether our findings are representative. And so if you look at stroke cases, across the board, slightly fewer women than men are coming into hospital with a stroke, around about 45%. Medical mimics, slightly more even. And when it comes to the functional mimics, there's definitely a female preponderance. And this was more evident in our study than when we look at the meta-analysis, but the trend is in the same direction. So more females, more women are having functional stroke than vascular stroke. What about age? So again, our study is reflected in the wider meta-analysis that the average age of a person coming into a stroke unit is around about 70 years. The medical mimics, people with tumors, seizures, other conditions, tend to be a little bit younger, but still in their 60s. And then there's definitely an age difference with the functional cases. We're finding that the average age is about 50. So young, quite a bit younger than the vascular strokes. And this just shows you the age distributions. So it's not only that the mean age of the functional group is lower, there's a much wider spread compared to vascular stroke cases, and even the medical mimics are somewhat more diverse. So we compared the presentations of the different kinds of stroke, the medical mimics and the functional mimics, for the kind of symptoms of presentation. So this is it in a table, which is, I can realize is a bit difficult to digest, but I'll show it in graphical form. I think it's easier to look at. So in terms of the pattern of weakness or numbness, the people with a stroke have commonly a weakness on the leg and the arm. The medical mimics tend less to have weakness, but the functional mimics are probably very similar in terms of arm or leg weakness. When it comes to weakness of the face, this is more characteristic of the vascular stroke, and that both the medical mimics and the functional cases are less likely to present with facial weakness. More dramatic differences occur with the less common stroke symptoms. So reduced consciousness, this is really marks out the people with the other medical conditions, often because they're presenting with a syncopal episode or a seizure, which is a rather unusual presentation of a vascular stroke. And then what it says, posterior circulation symptoms, double vision, vertigo, is quite common across the board. So not a very good distinguishing symptom. However, these other syndromes of stroke, dysarthria, dysphasia, they are very much the hallmark of a vascular stroke, and they don't tend to occur in these other conditions. And the syndrome of neglect, usually following a right hemisphere stroke, it's not that common. It's occurring in 25% of people with stroke, but you can say it never occurs in any other condition other than stroke. It never occurs in functional cases or medical cases, presumably because of the necessary brain regions and the fact that they are tied to the vascular territory of the parietal lobe, temporal parietal lobe, that results in neglect. Okay, and then other things that distinguish the different groups of patients in terms of their management. Well, the stroke service has CT as a routine, but not MRI. MRI is reserved for people with more complex presentation. So it's hardly surprising that it is these non-typical vascular strokes that end up having MRIs, particularly the functional group. And it's, as I say, not surprising because they're presenting with a slightly unusual picture, a diagnostic dilemma, and they require further investigation. CT angiography is also sometimes used for those cases. And then when it comes to the management, about a quarter are getting these clot busting drugs, tissue plasminogen activation drugs. Not all of the stroke cases, because some of them, they've had the syndrome too long, for too many hours or longer, they're not eligible. And you can see a small proportion of both the medical mimics and the functional mimics end up having the clot busting drugs, because presumably there's enough diagnostic uncertainty and it takes a while post hoc to come up with the right diagnosis. So here's some other interesting figures about management. So in terms of the time between the symptoms and arrival in hospital, it does seem to work that people are coming in very quickly. The functional cases always tend to have a slightly longer history. Again, a little bit of a pointer that they've got a different etiology. And then when it comes to length of stay, they stay less in the hospital. So to put it crudely, what happens is they come in with a suspected stroke to the stroke unit, and when the stroke physicians decide this isn't a stroke, they're booted out. They're sent home, mostly, often with no further treatment or follow-up. However, if you've had a stroke, you then tend to go to a different kind of stroke rehabilitation service, and the quality of care is extremely good. So again, it's not just that the duration of symptoms before admission is longer in the functional cases, it's more spread out, whereas in vascular stroke, it's very much a few hours. So again, a bit of a clue that the etiology is different. Something else is going on. Now, when you look at the past history, this wasn't available on the stroke cases because it's not part of the sort of standardized assessment. But when we look at the medical cases and the functional cases, there's a lot of other physical conditions. But what stands out is the past history of depression in the functional cases. And this is as documented in the case notes. So it's likely to be an underestimation across the board, but even so, it marks them out. There's also a lot of other medical conditions in the functional group: back pain, migraine, asthma, which may be important. But risk factors such as diabetes are common in both groups, and hypertension is particularly common in the medical mimics. Again, not surprising. So someone presents with a neurological syndrome and has high blood pressure, it tends to steer the clinicians towards making a diagnosis of a stroke. So it's a kind of reverse reasoning going on there. Now, this isn't really our field, but the medical diagnosis of cases that look like a stroke and then turn out not to be. There's a long list of medical conditions: epilepsy, migraine, space occupying lesion, Bell's palsy, etc. The one at the top there, previous stroke with functional decompensation, is what we call the case where it could be quite a frail elderly person who's got a history of stroke, who then seems to be becoming worse or takes a turn for the worse. It may be that they have a urinary tract infection or some other condition, but the people in the nursing home are worried that this might be a further stroke, and they sent the patient to hospital. So we call that functional decompensation, and it's quite a large group. Okay, so I'm now going to talk about what happens to these people. So they're rushed into hospital with the blue lights flashing. They have lots of tests and scans, and maybe treatment. And then when the dust settles, if they turn out not to have a stroke, as I say, they tend to be discharged very quickly with little follow-up. And so in the UK, they go back to their GP, the general practitioner, family doctor, to pick up the pieces. So we wrote to all of the general practitioners to find out what happened to their patients after discharge. Out of 98, we got 60 replies, which wasn't great, though not bad. And then out of those, we got good information on 40 cases. So it turned out that the majority were then redirected to a more mental health setting for psychological treatment of some kind, although a lot were referred back to neurology, so they may well still have neurological problems, and the range of medical specialties also comes in for further referral. So it's not as if the problem goes away, at least not for this group. And when it comes to the psychiatric diagnosis that we found in the GP records, depression was the commonest syndrome. Many were diagnosed with a, quote, stress-related condition, slightly vague, anxiety disorder, relative small proportion with somatoform type disorder, and a few with neuropsychiatric conditions other than stroke. So what about the people who we had feedback back from the GP, but they didn't mention anything to do with the stroke? Perhaps they'd recovered spontaneously, had sought help outside of the National Health Service, or maybe it's just become part of the family law. Person's had a stroke, they've come home, and we have to look after them, even though in fact they haven't had a stroke. So we wanted to find out a little bit more about what happened to these cases. So we collected another separate group of purely functional cases, over 50 cases over a short period from the local hospitals in London. But doing it prospectively, we're able to do some rating scales with some standardized ratings. So this is the SF36, a commonly used scale from the medical outcomes study that looks at function across a number of domains. And so this is 2 months after a person's admitted with, quotes, functional stroke, and higher score is better. So if you look at on the left there, physical functioning starts off low and improves over the 2 months. So it does suggest that there is some improvement in those basic symptoms, stroke-like symptoms. But if you look at the other domains, emotional well-being, for example, social functioning, these are not improving. In fact, there's a trend for them to getting slightly worse. So it really does suggest that there's some unmet need here. When we rated these patients for anxiety and depression, there's quite a high amount of morbidity. We compared them with other studies that we've done, for example, with people with chronic fatigue syndrome, and also a group with vascular stroke from a different study. And you find that anxiety is really quite common across the board. And post-stroke anxiety is a common psychiatric manifestation. So both the functional strokes and the vascular stroke are very likely, quite likely to have an anxiety disorder in the weeks and months following their presentation. Depression is also quite common, but more common in chronic fatigue syndrome than in functional stroke or vascular stroke. But the general levels, if you look at just the scores rather than the case notes, reveal a sort of mild to moderate levels of anxiety and depression in all of these groups. But I think anxiety is a key feature in this setting. So here's another graph showing scores on a behavioral response questionnaire. So this is questions that ask about adjustment or attitude to symptoms, and the questions are intended to bring out dysfunctional attitudes or beliefs and behaviors that might be prolonging the person's illness. So, for example, you can see that fear avoidance is very common in the functional stroke syndrome. That's in the dark columns. Sorry, that's quite high, but not as high as the chronic fatigue. It's in the next set of questions, damage beliefs. So this is very high in the functional stroke. So these people believe that they have been harmed and damaged in some way by their condition, despite the fact that hopefully they've been told they haven't had a stroke. And these sorts of attitudes are likely to prolong morbidity. Other kinds of things are this all or nothing thinking. That is, oh, I've had a stroke, I'm never going to get better, rather than having a slightly more nuanced view. So these are attitudes and beliefs driven by fear, but they're targets for a cognitive behavioral approach. Oh yes, so this is just a study from Richard Cannan's group in Melbourne, showing that people with functional stroke who end up having the clot busting drugs still do quite well. Perhaps it's a placebo effect, perhaps it's just because the patient's condition has been taken seriously. So there is a degree of recovery there. So how can we take this work forward? Clearly, we've got to try and understand the functional stroke. It presents clinicians with a dilemma. They want to make the right diagnosis. Either way, they don't want to miss a case of stroke and then miss the opportunity to give clot-busting drugs. On the other hand, to misdiagnose a functional disorder has consequences, and means that that person isn't getting the kind of rehabilitation that they might need. So what we need to find out and work out is better care pathways and better therapeutic interventions. So we've started to at least map out what might be going on in functional stroke, and therefore what we might do to manage the condition. And so, drawing on knowledge of other functional conditions, here's a kind of scheme that includes predisposing factors, early life experience of stroke, say in the family, precipitating factors, physical conditions going on in the individual or stresses at the time, and then when the symptoms develop, perhaps through anxiety symptoms of tingling, of headache, of blurred vision, then a series of attributions comes in, their beliefs about what might be going on, the attitudes of other people. So, of course, a person is being swept up in the medical world by ambulances and doctors, injections and scans. So if you weren't really worried about your health to start with, you certainly would be by the end of that. And then relatives, assuming that you've had a terrible stroke that's incurable rather than a condition that might be curable, that can feed into your beliefs. You can start seeing yourself as a stroke victim, and you might have a very pessimistic view of what that means. And all of that is going to perpetuate your symptoms. So here's just a vignette from one of our cases, just to illustrate how this might work. So we have a middle-aged man who's brought by ambulance to a hospital after collapsing, feeling that his right side was weak. So those were the symptoms. His wife rang the ambulance, so the behavior of other people was coming in there. She remembers the stroke campaigns on the TV, which heightened her anxiety. He's admitted he has thrombolysis, which again is going to reinforce his view that he must have had a stroke. He's doing quite well. He's quite a high functioning person in a good job with a stable family, but his work is stressful. And at the time of his admission, there were a lot of problems at work with redundancies, and he was very worried about his work, and he was working long hours. And again, the family were reinforcing that these symptoms were out of character for him, this having headaches and weakness. So in terms of his medical history, he has high blood pressure. So that's again going to focus his mind. He has had headaches, which again might make him think that there's something going on in his mind. And that's unusual for him. His father had a stroke, and his grandfather also suffered from stroke. So again, there's some model in the family that might be predisposing. So the patient had follow-up scans which confirmed that there wasn't a stroke, but he still had some mild weakness and word finding difficulties. So word finding difficulties can be quite a common feature of life. And if you're very anxious, you might notice this more and think it might be a symptom. So it's your kind of how you label these symptoms that has great implications. The family started monitoring and looking out for problems, and whenever he said he couldn't remember something, they would then sort of look at each other and say, oh, that's the stroke playing up. So this sort of checking and reinforcing may well have had an effect on perpetuating the symptom. And then the fact that there was not a clear pathway of what the next steps were, again, that can only have increased anxiety and perhaps perpetuated the condition. So I think a much more rigorous look at how we manage these people using physical rehabilitation, cognitive behavioral approaches, we're likely to have much better outcomes. So in summary, the acute management of stroke has been transformed, revolutionized in recent years because of the thrombolytic treatment, and that saved many lives. But a quarter or so of people admitted to stroke units don't have a stroke, and about up to 8% have a functional disorder. The presentations may be different. The mimics are often more likely to be female and younger, but of course young females have strokes as well, so that doesn't make it easy for the clinician, but they should look out for depression, which would need treating in his own right, and may raise questions about the diagnosis. The physical prognosis may be quite good in this group. They're an older group than most functional disorder patients. It may be that they have quite good coping strategies generally, but have just been swept up in the stroke system because of the low threshold to admit people to hospital. So maybe that this is a good prognosis group if we get there early and do the right things. But treatment pathways, as I say, for such cases are desperately needed within stroke services. And I think that they could make a big contribution to improving the outcomes of all of the patients. So here are some references for further reading. But that's the end of my presentation. So I'll very much look forward to any questions you might have.
Thank you so much, Tony. That was an excellent presentation. I think it's a wonderful study, although retrospective. And as you rightly say, that we need more prospective studies, which will take some time to put together. There are not many questions at this point, but I have some questions I can start off with. But there's one question that's come from one of the attendees, and that's in relation to complex trauma background. I think FND, generally complex trauma does figure in many cases. So is that something you've looked at? You did in your model, you did mention trauma, but is it something that you have examined or others have examined?
We haven't looked at that systematically, but I think it's one of the factors, one of those predisposing factors that I might have mentioned. I wouldn't want to overdo it. I think it's probably a minority of people that have that in their histories and in a way that might connect to presenting later in life. But it certainly does come up. And it can be that people presenting in their 50s and 60s may well have had some very disturbing early life traumas that's led them to sometimes dissociate. And that can present in this way, but I'd say it's a minority of cases, and we shouldn't be sort of overly eager to uncover trauma where it doesn't really exist, because I think it's what's happening in the here and now that is much more relevant to these kinds of cases. It's all about the symptoms of anxiety being leading to physical symptoms that are then channeled down a stroke route. I think it's more to do with what's happening in the here and now than perhaps what's happened in a person's past.
So there's a lot of interest in the mental health profile of these people. And of course, they have a history of depression. But are they currently depressed as well, you think? Or is it anxiety largely that you see in these people? What about other somatic symptoms, other presentations, similar functional neurological presentations?
Yeah, I think this is what makes this group rather interesting, because yes, I think anxiety is the predominant current mental state, with some depression. And of course, there are some who've had previous episodes of functional disorders or somatization. But again, that's a minority. So I think these aren't people who've had a long history of different functional disorders and now they're presenting to a stroke unit. I think they can be people who have not really had those sorts of problems before, and a combination of their life stage, the fact they may be now having treatment for high blood pressure, they're rather anxious individuals. They're seeing these adverts on the TV. They're wondering about their health a little bit, perhaps too much, and one thing leads to another. But I think it means that as individuals, they're quite able to overcome this with the right help and advice, and they're not people who have had a long chronic history of recurrent conditions. So I think they're a nice group to treat in the sense that there can be a lot of optimism about helping them get through this.
So, a related issue, I guess, the question that Kimberly has raised is the pathway that you follow. I mean, should you let them go through the rigor of the stroke investigations, the MRI scans, et cetera, or is it that you make an early diagnosis of functional mimic and then intervene? Would that be counterproductive in some way?
Well, Yeah, I mean, there's obviously a real balance here about, and of course, people in psychiatry, perhaps we're overly sensitive to, as it were, missing a diagnosis, missing an organic diagnosis, and that sort of living with us all our lives. But of course, mistakes will be made, misclassifications are made. And as we both know, there's far more people with really treatable depression, for example, that's being missed in medical settings than the other way around. But we need to have a balance, and I think it's quite right that people have thorough investigation at the presentation, but it shouldn't be a case of, well, let's just do one more test just in case. So I think it does need an experienced clinician to be able to say on the, on the balance of probabilities, and especially if there are these sort of positive signs of functional disorder, to make that diagnosis and follow it through. So it does require a good team, a multidisciplinary team, where they can share uncertainty, but making the wrong diagnosis can have effects in both directions.
Yeah, because see, I mean, I've done on-call psychiatry for several years, but I don't remember a case where a patient who came in with suspected stroke and was referred to psychiatry in the ED. It does happen later, but in the ED, I think it rarely happens. Is that your experience as well?
Yeah, I think that's probably right. They tend to err on the side of this being a physical diagnosis, and there in the ED you're having less experienced doctors and clinicians. That's true, and a lot of labels are used that are slightly hiding uncertainty. So migraine, I hear a lot, and it's people who have a little bit of headache and they have transient symptoms down one side. It's very hemiplegic migraine is a real condition, but my neurologists tell me it's very rare and it tends to be familial. But an awful lot of people get diagnosed with hemiplegic migraine and sent home, and that might be kind of satisfying in the short term, but in the long term, it's not very satisfying.
Yeah. The other point I wanted to actually get your comments on was the images that you showed on the FAST, the rather anxiety-provoking images. Do you think that campaign has had an effect? You think there's been a rise in mimics over this period?
Yeah, I mean, I do have a slide on that, but so there was a study done, I think, in Norway that looked at the change before and after these campaigns, and there had been an increase in stroke mimics in general following the campaign. So I think it is a side effect, as it were, of that. But again, it's the same question of, if overall it's doing good, like any treatment in medicine, there are side effects. So I think the public health message could be more positive, rather than being based on fear. It's you have this symptom, quickly find out what it is. It may be a stroke, rather than, and it may be something else, but it's good. It would be good if you found out. But that's quite a complicated message, and you can see why it's easier to go for a simple message.
That's true. Yeah, it's true. Now, Adit actually has raised the issue of the services, really. And I think there are some systemic differences between the UK and Australia, he thinks, in terms of the acute services for stroke. But I suspect it's neurology that manages acute stroke in the UK as well, or is it geriatrics?
Well, it's interesting. You have this new breed of stroke physician. Yeah. And they may have a neurology background, or they may be sort of a vascular cardiology physicians.
Okay. Yeah.
And so that's quite interesting, because there are some tensions within stroke services where the neurologists tend to be, I think, better at the phenomenology and the diagnosis of particular syndromes, as you might expect. Whereas to the vascular clinician, they don't really care which lobe or which syndrome. If it's a stroke, they want to get rid of the clot. But neither of them really are very attuned to functional cases, I'm afraid.
Sure. So what is the role of a psychiatrist in a stroke service, you think, or a neuropsychiatrist?
Well, I think we can have a good role, because I think they're good clinicians. They know what they're doing, and they often will use terms like functional overlay. But they don't really know how to go beyond that. So I think psychiatrists can show that there are positive signs of functional disorder. They can alert the clinicians for trying to look at anxiety and depression. That's not to say, well, if a person's anxious and depressed, they can't have a stroke, because we showed that people who've had stroke also have a lot of anxiety, but nevertheless, they can attend to that more. And then I think make a clear diagnosis early on in a way that is positive. Not that you don't have a stroke, all the tests are normal, goodbye. It's more that you have a functional disorder, it's different from a stroke. That's why the scans were negative. And then this is what you must do. It means that your brain is not damaged. You should be able to recover, but it's a question of relearning how to work those limbs again, or attending to what provokes the symptoms. And then I guess would have to have therapists who can take on the cases beyond that, because the neurologists aren't going to be able to do that. They can make a big difference by making a clear diagnosis, but they all need a multidisciplinary team to take things forward after that.
So in your experience, would the rehab physicians take on some of these functional mimics as well?
Well, some of them are very interested and keen to do that, but some of their services are constructed in such a way that they would say, we're not allowed. We're only allowed to take people who've had a stroke. If they haven't had a stroke, they can't come into our service, which is, I think, a very, very narrow-minded problem. And it comes from the people commissioning the services. They have to accept, they have to embrace all the different kinds of
that's an excellent point, really. So there's one question from Kara Salehi, who's a registrar, one of our registrars, about differences between functional strokes and other FNDs. Or you think, I mean, you mentioned some points really in terms of age, etc. But do you think generally in terms of prognosis, in terms of etiological factors, are there major differences, you think?
Yeah, I think there's obviously overlap, and some people presenting with a stroke, they do have a history of, say, non-epileptic seizures or other conditions. But in general, they are an older group, and it's more to do with anxiety symptoms, the physical symptoms of anxiety being misinterpreted. So I think that applies less to other functional disorder groups who have, I think, other beliefs about their body and about bodily functioning. So I think there are differences, and it does require a slightly different approach.
And finally, in terms of neglect, there's something you mentioned, it never occurs. I suppose, again, it comes to the same thing, doesn't it, in terms of functional symptoms, that it's the individual's, the patient's conceptualization of how the brain works, or how the brain controls the body, so to speak. Would you say that's...
I think it is interesting. It's just not, it isn't in general people's understanding of what a stroke does. So I think cultural views of illness and expectations, they do shape presentations, functional presentations. They that's not to say people are mimicking deliberately, but these things get into the psyche and they do shape the way people present.
Yeah, absolutely.
But it is I mean, if there was a film or a play about someone with neglect that became very popular, you would predict that you'd start to see more of that in the functional presentations.
Absolutely. I hope that's not in your book and you're not popularizing.
Well, you'll have to wait and see. Why don't you have a look?
No, thank you so much. That's been a wonderful presentation. It's lovely to learn so much from you, Tony. And I want to thank all the attendees and encourage them to actually complete a survey after the talk so that we can hopefully improve or continues to deliver, to bring such great talks to everybody here. We also I'd also like to, again, put in a plug for your book, Into the Abyss, a neuropsychiatrist note on troubled minds, available from Amazon. And we are, of course, eager to get more information for future lecture series events. So please take the time to complete the survey. And to register for future lectures, please make sure you subscribe to Chiba's newsletter or check our website. So thank you and goodbye now.